talk on strategic selection of patients for MIS adult deformity by an OLIF. So we all know, and it has been talked before also by, I think, probably he might have taken that the surgical goals for adult spinal deformity is neural decompression. So that is the primary aim where the patient is coming to us. So that's our primary aim. But the secondary aim is around also the alignment of the spine and achieve fusion with fixation in a good sagittal balance. So that's our primary goal for adult spinal deformity. And these sagittal parameters are already talked about by Dr. Guru. And whenever you go for a long fixations for adult spinal deformity, you need to definitely consider all these sagittal parameters. And they are very, very important. But if you see SVA or sacral slope or any of these parameters, the crux of all this thing is to achieve a lordosis in the lumbar spine. Because everything is related and revolving around achieving the lordosis in the lumbar spine. So that is the crux of the whole deformity correction or this achieving the sagittal balance. And as Dr. Dalvi said that open surgery, yes, it can achieve all these goals. Definitely, and we were doing this and we are doing as on today also, not all the patients we are doing by OLIF. So we are also having this, but there is too high a complication rate. If you want to do anterior fusion at all the levels, like as in this case, if you want to do a TLIF at all the levels to get a good lordosis, because you want to achieve a lordosis and each segment you need to do an anterior fusion to get this lordosis. So there is high blood loss, more levels to be fused. There can be more medical complication. There are need for osteotomies in rigid cases. So these are the downsides of these things. And whether we can achieve the same goals by an MIS surgery, yes, we can achieve the same goals, and this has been very well demonstrated, and I'll also show some of the cases for these things. So there are so many MIS techniques that you can use. OLIF is one of the major or the workhorse for the adult spinal deformity, and that is where the place of OLIF is very much compared to any other place of OLIF doing anterior fusion. So what are the advantages of OLIF in this deformity correction? You can do a multi-level anterior intra-body fusion. I think that's one of the very important thing. The second is it gives a better lordosis per level compared to TLIF. So TLIF gives around 1.2 degrees or maximum 2 degrees of lordosis per level, while OLIF will give around 5.2 degrees per level if you do the OLIF. So you can compensate about 15 to 20 degrees of PILL mismatch. If you do it at 3 levels, if you do and extend one more, you can have a little bit more of these things. So you can get an overall better sagittal alignment with shorter number of fused levels. It's very obvious that if you get a more lordosis, you are able to compensate to the whole spine, and you can see the whole spine getting corrected by doing this procedure. So it can be combined with ACR if you are technically sound, and it avoids major osteotomies in rigid curves. And I think you can combine it with a hybrid, and so many times you can use a hybrid in rigid type of a deformity, where you can get a good sagittal alignment and do a posterior. If you want to do a decompression, as was last case, you can do a hybrid along with it. And it decreases overall complication rates compared to the open surgery, and you get a good indirect decompression and fusion. That's the other advantage of OLIF. So these are the advantages of doing an OLIF. So the strategic questions are when and how to select the patient for OLIF for adult spinal deformity. So you should know what is your target, what is the flexibility of the curve, what are the technical hitches, and when to add hybrid posterior technique. So if I can answer all these things, that's better. So if you have a mild to moderate deformity and a flexible curve, so this is where it's one of the easiest thing to do by an OLIF, where PILL mismatch is less than 25 and SVA is less than 10. You have mobile discs on flexion and extension views, and there is no facet fusion. And these targets can be achieved by all 4 levels, L1, 2, 2, 3, 3, 4, 4, 5, by doing a lateral fusions and with a compression from the posterior percutaneous pedicle screws. So if this is one of the very good articles where you can see that there was an algorithm, selection algorithm in correction of ASD, and you can see that if you do from L12 to L45, 90% of the surgeons are now shifting to doing anterior fusion or laterals compared to the other TLIF procedure in adult spinal deformity. And this is again a similar article where they have shown that segmental lordosis values by level and interbody fusion. So if you see the interbody, if you see the lateral fusions, it gives much more lordosis compared to the TLIF, the standard TLIF that we do. So there is no doubt that the OLIF works better. So in one of our papers that we have studied that 103 levels and we assess the segmental lordosis how can be achieved by 6 degree kgs, and average increase in segmental lordosis was 5.23 per level by doing an OLIF. So you can get a good, alignment. What are the limitations of the OLIF? The anteriorly, there is a rigid ligament ALL. So that's one of the limitation, and posteriorly there are degenerated facet joints. So these are the two limitations. So you cannot get 100% correction by these things. So OLIF or lateral fusions can give you fair moderate degree of correction, but if you want a little bit more, then you have to do a posterior correction by a compression from the posterior. So how can we assess the rigidity of the deformity? The rigidity of the deformity can be assessed by full extension lateral views, and this is what we also do. So some case examples and then I'll stop. So this is a mild flexible deformity, and you can see that PILL mismatch was on standing X-rays 25, but if you see that the same thing gets corrected in extension to PILL 12, so this is a flexible deformity, you can get a good correction, and this is what we did, and that's a complete MIS procedure. And you can see that's the first stage, you can see that's the first stage, and then that's the second stage, and the PILL which was 25, which has been corrected to 7 in a full length X-ray with a good coronal as well as sagittal alignment. And this is what you can see that how this thoracic spine has also corrected if you just get this full length X-ray that you can evaluate. So similarly, another patient with a PILL mismatch of now 30, and in extension view got a PILL of 11, and it's a moderate deformity because the mismatch was 30, but it was a flexible deformity. And with the same 3-level OLIF, you can get a PILL of 14, and you can see a good correction of the overall alignment. Moderate deformity, severe than this, and it's a 28 degree scoliosis, PILL mismatch of 30, and a gross SVA malalignment. And just doing, again, it was a mismatch of 17 if you do a full extension lateral view. So then still, you can see with, this was on hybrid done, but you can see that with hybrid also, you can see it's got completely corrected, and the PILL mismatch was only 1. So that's how it helps in correction. And that's a severe deformity. That was the case that similar what Dr. Samir showed. And you can see that PILL is 36, and this requires a fusion to sacrum. And you can see that we have 1, 2, 3, 4, 3 OLIF and 1 TLIF, and then S2AI screw. And then you can see PILL mismatch was corrected to completely 2, and with a good sagittal correction. And so when not to do MIS, we all know that you cannot do the MIS when there is a rigid deformity. So this is where we cannot do the MIS. So in the rest of the things, you can do the whole OLIF procedure. So these are the selection criteria that I use when to do CMIS, when to do hybrid, and when to do open in this. Thank you very much.